Hi.
Welcome. It is 1:09 on the 25th of April. And today we have in with us VPQHC. And they're going to give us kind of an overview of what it is they do and also comment on S126 because they are a part of it. So thank you. Hillary,
Thank
go
you so
ahead.
much for having us today. My name is Hillary Wolfley. I'm the executive director at VPQHC. I just became the executive director this past July, but I've been with the organization for 10 years. I have a background in public health and international development studies, and we're very excited to be able to share some information about our organization and the work that we do. I just sent a request. I do have some slides that we prepared. So I just sent a request to be able to share. Thank you. Can everybody see those?
We can.
Okay, great. So we've been asked to come and provide a presentation today on the topics outlined here. So first we'll open with an overview of who VPQHC is and the work that we do. We'll provide an overview of a few of our current initiatives. I did send a handout with a summary of, we have, I believe, 18 or 19 current projects. So we don't have time to go over all of those today. We'll do a deeper dive into 3 or 4. But if you have any questions about the projects that are listed on that inventory, please feel free to ask them. We'll then move on to an overview of the value VPQHC brings and our comments on S126. Does this look okay to you all still?
Terrific.
Okay. Okay, hold on. My mouse is not letting me. So VPQHC is a 501c3 nonprofit organization founded in 1988 and designated in 1989 by the Vermont legislature as an independent, non-regulatory peer review committee. Vermont's 9416 statute established VPQHC as a statewide quality organization in 1995. Our mission is to improve healthcare quality, reduce harm, and save lives in Vermont by advancing data-driven solutions. VPQHC has 14 staff members who bring decades of experience in healthcare quality. Several of the folks that work at VPQHC have direct service experience across the continuum of care in Vermont. And you'll hear my colleagues that are here with me today will introduce themselves when their slides come up. So you'll hear from a few of them today. VPQHC is overseen by a diverse board of directors. We have representation from across the continuum of care, including from the UVM Health Network, Mount Ascutney Hospital, Bi-State Primary Care, the Hospital Association, the Medical Society, designated agencies, state agencies, insurers, mental health advocates, and the Healthcare Advocates Office. And I went through that list because the board is one of our strengths and is representative of how VPQHC works across the system, bringing together at many times diverging viewpoints to work towards common goals with a focus on quality improvement. So this has really been our message up at the State House this year. We're not up that often. We're not a lobbying organization, but just making sure that quality continues to be a part of the conversation. There's been a lot of focus on access and cost. And that makes a lot of sense, but just making sure that quality remains central as well. We need all three. We can't just focus on one without considering the others. And when we were preparing for this, Morgan, who you see on the screen, said, picture this like a 3-legged stool. If you remove one leg, the stool no longer functions. So if you make care really cheap, but the quality suffers, that's not good. If you invest heavily in top quality care, but it's too expensive or hard to reach, that's not good either. And if you expand access without controlling costs or maintaining quality, the system can become overwhelmed or inefficient. So it's really important to design healthcare reforms, policies, and services that expand access, keep costs sustainable, and improve or maintain high quality all at the same time. So as legislators, I would certainly encourage you to ask when you hear presentations and proposals being brought to you for different reforms, that you ask, how is quality going to be impacted by this plan? And how have you considered quality in this plan? VPQHC's funding, we do receive bill back funding in the amount of $660,000 annually, but that cannot make up more than 75% of our total operating budget. So we have many other funding sources in the form of grants, contracts, and philanthropic contributions. Given the current federal environment, we're keeping a close eye on this. And our bill back accounts currently for 29% of our organization's total operating budget. So I think this will wrap up this section. I did, as mentioned, I provided a handout with an inventory of all of our current initiatives, also a timeline of the work that we've been engaged in since we were founded. We've been working on quality improvement initiatives in Vermont for 37 years. And again, we work across the system. So we have many current initiatives with groups such as primary care, hospitals, designated agencies, independent providers, and we also work with the correctional system on quality improvement work. So what value VPQHC brings? We're an independent organization solely focused on healthcare quality. We have deep quality improvement expertise at the organization. We're Vermont-based, and we have Vermont priorities with national and international perspective at the organization. We're a collaborative partner with a proven track record of implementing sustainable systems-level change. We're a trusted neutral convener, and we really work to promote efficient, aligned implementation of quality initiatives to reduce duplication and maximize impact. So now we're going to go into a few examples of a few of our projects. And I'm going to pass it to Morgan.
Hi, everyone. I'm Morgan Bedard. I'm a quality improvement specialist at VPQHC. I'm a social worker by training with hospital-based experience as a care manager and as a quality director at a Vermont hospital. I'm also certified as a certified professional in healthcare quality, which complements my hands-on experience leading cross-functional teams. My experience with VPQ is unique because I was a consumer of VPQ as a quality director, including reporting into this patient safety program that I'm about to overview for you. And now I'm managing this program and able to support the hospitals with it. The Patient Safety Surveillance and Improvement System was established by statute. It monitors serious reportable events and intentional unsafe acts that happen at our hospitals and ambulatory surgery centers. Intentional unsafe acts are defined by our statute, but serious reportable events are defined by the National Quality Forum. There's a link at the bottom to that list. The program collects adverse event data and it supports causal analyses where hospitals are looking into what happened and how an event occurred, which promotes improvement while maintaining important confidentiality protections. As Hillary mentioned, VPQHC is a peer review protected organization. We are contracted by the Department of Health to administer this program. And a statewide system is important because it allows you to identify trends and systemic issues beyond a single institution's scope, and it facilitates shared learning across facilities. So I'm able to connect hospitals who may be seeing similar events. Next slide.
I think we have a question, Morgan.
Sure.
Morgan, you said something about being peer review protected. What does that mean?
Sure. In short, it's a legal-based question, but it allows us to support the hospital's peer protection of their analyses. So based on the way our statute and a federal statute, the PSQIA is written, analyses of patient safety work product should not be admissible, for example, into the court of law. So it's really important for hospitals to be able to openly analyze events and report them in a non-punitive environment. So there's honesty, and so there's a genuine review of what happened to prevent a recurrence. So enabling that confidentiality, which VPQHC is able to support, helps the hospitals be honest with us because the results of their analyses then cannot be introduced into litigation, theoretically.
Great, thank you.
This slide overviews a few of the broader system values and returns of having a strong safety program. This can reduce claims expenses through systematic prevention of patient harm. And really importantly, it can decrease avoidable healthcare utilization. We don't have an excess of services looking for patients right now in Vermont. So I'm going to give you a few examples just to drive this home. So in this first sub-bullet, I'm talking about hospital-acquired conditions and hospital-acquired infections. These can be known to increase your length of stay. So if you go into the hospital to be treated for one thing and you fall and fracture a bone or end up with a brain bleed from a fall, that's going to increase your length of stay, prohibiting the next patient from entering into that bed. That goes beyond length of stay and bed availability. If you look at the next bullet, if you have an injurious fall and you need radiology imaging, well, now you have that imaging staff and the imaging equipment taken up for an injury that was caused at the hospital, totally unrelated to why the patient presented there. That's similar to the third bullet, where if you have a retained foreign object from an invasive procedure or a surgery, there could be an additional, otherwise unnecessary surgery or emergency department visit or primary care visit to address this retained foreign object. Similarly, there's really intensive inpatient and outpatient care and coordination required to heal an advanced staged hospital-acquired pressure injury. So it really adds insult to injury when you continuously add on these otherwise unnecessary services, which makes their availability for patients who need them for non-hospital acquired conditions. A strong patient safety program can also lower facility spending on these hospital acquired conditions that they are not getting reimbursed by insurance for. It improves quality metrics that impact value-based reimbursements. And what's important to all of us here around the table, a common theme, is that it aligns quality improvement with the common goal we all have to decrease preventable harm. So when all the oars are rowing in the same direction, you can really see some great benefit there.
Thanks, Morgan. The next program we're going to provide an overview is our work with emergency departments on improving the quality of care for patients who present experiencing suicidality. We've included a couple of statistics here. Suicide is a serious public health issue with more than 49,000 lives lost nationally in 2022. In Vermont, 125 individuals died by suicide in 2023, and data show that 65% of those who died had visited a healthcare provider within a year of their death, and 35% had visited an ED within a year of death, making these settings a unique opportunity to prevent deaths by suicide. Since March of 2022, VPQHC has been leading the Vermont Emergency Department Suicide Prevention Quality Improvement Initiative. What we've been doing under this program and how we're supporting sites, we're supporting them with implementing evidence-based care pathways. We're requiring training and counseling on access to lethal means. We found out early on in the project that most emergency department professionals had never received suicide prevention training ever in the past. We're providing technical assistance, workflow analysis, and on-site mock surveys. We are running quarterly meetings under our Quality Improvement Collaborative to support peer-to-peer learning with hospitals, emergency department staff, and designated agency staff. We also connect through those sessions with subject matter experts in the field. And we also support the sites with data-driven quality improvement and require measures to kind of understand the progress that they're making with their quality improvement work under this initiative.
Hillary, we have another question.
Okay.
Hillary, this is great work around suicide prevention. I'm curious if it's part of Zero Suicide and attached to that funding.
So it is following the Zero Suicide framework. We work closely with the Department of Mental Health, and actually the subject matter expert that's a part of this project helped write the Zero Suicide framework. So it's not, Zero Suicide is pretty more robust than this. So it's really through this, we're focusing on evidence-based care pathways, but it is a part of that framework, yes. but we're funded through the Department of Health. We have philanthropic funding for this, and through the Four Pines Fund and the Vermont Community Foundation. So we're not funded through the Department of Mental Health for this initiative, specifically.
Okay.
So impact highlights to date, we've had 93 to 100% voluntary hospital participation in this program. All of the emergency departments in this third year are implementing pathways that align with the essential elements of a suicide care pathway. We've trained over 400 emergency department staff in counseling on access to lethal means, and safety improvements from our immediate safety improvements were made from our on-site mock surveys. And just to bring it to the patient level, I've highlighted an example on the right that at Northwestern Medical Center, they've been working closely with Northwestern Counseling and Support Services, which is their local designated agency, to implement universal screening in their ED under this project. Over the first 8 weeks of implementation, 251 patients were identified as having suicide-related concerns. 53 were actively considering suicide, and 11 individuals disclosed suicidal thoughts despite arriving with non-mental health related concerns. Without the new procedures, these 11 patients may not have gotten the resources or treatment for their suicide concerns. At the bottom, you'll see this initiative was featured in a recent article by the Pew Charitable Trusts and recognized for its excellence in innovation and quality improvement by the Federal Office of Rural Health Policy. Further, it informed what is in Vermont's model protocol for suicide prevention for healthcare facilities that was submitted by the Department of Mental Health to the legislature. And we are working now to expand this to primary care and more robustly to bringing in our designated agency partners under the Center of Excellence for Suicide Prevention in Vermont. Right. Randy, you're up.
Yes, good afternoon, everyone. My name is Randy Messier. I'm a quality improvement specialist with VPQHC. I started out my career in medical laboratory sciences. I have a bachelor's in science and medical laboratory science. I have a master's in science administration from St. Michael's College, and a certificate in value-based care from the Dartmouth Institute. And I'm also a certified content expert for medical homes. For many years, I ran the hematology lab and taught hematology at the University of Vermont. I then became the director of primary care, internal medicine, and family medicine. I had 8 clinics, an urgent care center, a palliative care program, and a hospitalist service. I brought my primary care programs through quality improvement and realized I really like that a lot better than managing all the practices. So with that, I started a career in quality improvement and working with the Dartmouth Institute and teaching team-based coaching in that program nationally, internationally. I then joined UNH as the director of team-based quality improvement coaching and taught quality improvement to graduate nursing students, as well as in Saudi Arabia, Australia, Sweden, and England. And that work, which was always a pleasure to learn from others in those areas. I've also published many articles and written chapters on integrating behavioral health in primary care, using quality improvement measurement to improve the systems of care and to improve the care for people with cystic fibrosis and multiple sclerosis. And I've had the joy and the ability to do that while living in Vermont this whole time. So it's been a pleasure. And I joined VPQHC about 2 years ago. So it's good to be back and to be working locally again. What we have here is we have the opportunity to partner with Howard Center to work with them on their bed-based programs. We worked with them to standardize some of the clinical and operational procedures across all 26 of their programs. We did this by addressing variation across the practices to align some of the systems and processes that they had between their bed-based programs, which all have a slightly different flavor based on the population they're supporting. This helped them with resource utilization and to capitalize on really having a greater understanding of their whole programs, so that in a time of high turnover and workforce, limited workforce here, they're actually able to better optimize the work that they have and standardize it across the groups. We're on year 2 of this work with them, and it's been a pleasure helping them improve those systems across their bed-based programs. Next slide, please. We've also had the opportunity to work with a pediatric practice in Franklin County. And we joined this group. They asked us to join them to help them to implement social determinants of health screening within their primary care practice. When we started working with them, less than 20% of their patients were being screened for health-related social needs. Now they're between 85 and 90% of their patients being screened at well child visits within their programs. Within these 2 clinics in St. Albans and Enosburg, they discovered that 14% of all their patients had health-related social needs, mostly in housing, food, transportation, and safety, which was, we would say was news to them, but it was a surprise that it was that high percentage of their population. And this is data that they capture monthly and bring back to their providers and their staff, so everyone has the most up-to-date information about their population. When I asked the lead physician, you can see on the right, when I asked the lead physician what kept her up at night, she said, I think we provide the best care to the people that we see. I'm concerned about those that don't, that the children that are not coming in for the preventative care that they need. So we took a look at the health-related social needs of that population, and we found that those patients that had 3 or more no-shows had a higher rate of housing issues, food insecurity, transportation, and safety. Well, instead of just stepping back and admiring the problem, they said we need to do something about this. So they used the Blueprint expansion funds to implement a community health worker program. Now, they had community health teams there that were working within that structure, but we developed a community health worker program for that group with structured processes and procedures to move them forward. But we wanted to make sure that this was cost effective. We didn't just want to add one more person into the system. So on the bottom left, you can see 2 lines. One of them is the number of encounters, the darker line, and then the lighter bluish green line is the cost per encounter. As you can see, even though we added an expense into our system, because we were able to support more patients, the cost per our support dropped over time within that work. So the cost per patient is down. So we added staff, but the cost went down, which is a good measure. On the far right, you can see an example of what this really means in the real world. We had a mother and a child who was jaundice and needed to be seen. This family had transportation issues, and in the past, when this occurred, they had called the ambulance because they knew the ambulance would take them to the hospital. That was their transportation to get there, even though the baby did not require that level of service. With our community health worker program, we were able to actually deploy the health worker to go out and pick up the mother and child, to bring them in to get the right level of service within the clinic with people who knew them. And you can see at the bottom the difference in the cost. When they went to the ER before, it was $2,564 cost to us for a service that really wasn't required at that level. On the right, it was $60. It's this kind of thing that goes on continuously within a lot of our practices in the state, that money gets kind of hidden. Unfortunately, for many of these programs, the Blueprint expansion funding ends in June, so a lot of the programs, this work may be ending. With this program, we've actually managed to spread some of this work amongst other people within the clinic so that we're not losing all the benefit that was gained. This is the way we're able to still monitor this program, feed that information back, and continuously make changes to make sure that we're able to still accommodate these patients.
Thanks, Randy. We have one more project that we're going to highlight, and then we can move on to S126.
Thanks so much, Hillary, for inviting us to present here. So my name is Greta Spotswood. I'm a child psychiatrist, medical director of the Vermont Consultation and Psychiatry Access Program. And we are now under the VPQ umbrella as of this fall, and very excited to see what collaborations we might do with our home here. Next, please. So just to summarize what Vermont CPAP program does, we provide free immediate support and psychiatric consultation to medical providers in primary care in order to increase their skills and confidence in managing initially pediatric and now also perinatal mental health conditions. So when we're thinking about that pyramid of access, cost, and quality, we are trying to hit all three of those with our program. So we try to harness collaborative relationships and evidence-based strategies in order to improve this mental health care for children, caregivers, and also perinatal people. I'll tell you a little bit more about how this works next. I know I don't have to spend much time convincing you that the pediatric mental health needs are increasing in frequency and acuity. And primary care is often the first point of contact for these needs. In 30% of cases, the PCP is the only provider for this needed mental health care. What we hear from primary care providers around Vermont, some of them have been doing this work for years. They tell us because of lack of access, they've just learned to be able to step up and treat kind of really high level mental health needs. So we hear that from some of them. And then what we hear from a lot of them is that they feel like they have not enough training or limited training in treating mental health conditions when they start working in clinics, or even if they've been working in clinics for a long time. Next. So our goal is to support provider skill and confidence increasing, and ultimately to have fewer referrals occurring to higher levels of care. We still know that there are many children and perinatal people who require higher levels of care, and we want those people with the higher levels of need to be able to access the higher levels of care more quickly. And we've also heard back from providers that this service is reducing provider burnout. We're really happy to report that 85% of primary care providers reported improvement in their working life because of the support we're able to provide them. And then we've also been learning that 60% of primary care providers would have made a referral pretty immediately if they didn't have our service to call. So this would be, exactly what we're hoping for, that the right referrals still get to those higher levels of care, but they get there faster, and referrals that we can support continuing care in their primary care home, remain in the home, and receive appropriate care very quickly rather than being on a wait list for a long time. So we're hoping that is because those referrals are not happening to higher levels of care, people are getting cared for more quickly in their primary care home with the appropriate mental health supports, that will increase access, decrease cost, and increase quality. Next.
Yep,
So
I think we have a question, Greta.
Before you, oh, wait a minute, this may answer my question.
Oh, do you want her to go through this slide first and then maybe ask it after?
No,
Okay, you're gonna ask now?
yeah.
Okay.
In terms of the people that are being referred, what are the problems that they're having?
Yep. So the questions that we're answering are the problems that you'd expect, things like anxiety, depression, ADHD questions. So those are pretty much consistently at the top of the list of the questions we get from primary care providers. After we talk with the primary care provider, we might have some questions about broadening that differential diagnosis to include things like trauma or things like neurodiversity. We also get questions about those things, just not at the frequency. So we're answering questions about problems that we might consider mild to moderate, but we're also kind of broadening the differential diagnosis and walking the primary care provider through the screening tools or other tools that they might need to more clearly understand what's going on and make a targeted treatment plan. Does that?
And so then does the primary care provider take that patient over completely?
Yeah. So actually, if you can go to the next slide here, and then I'll come back to this one.
Okay.
Okay, great. So your questions are so good. So what we think about is the level of need for these patients. And we're thinking about this from a mental health perspective, whereas the primary care provider is kind of thinking about it from like their training perspective. If someone has exceeded what they're comfortable treating, the right thing to do is to refer and to get a higher level of care for that patient. So they're really doing the right thing. What we're trying to do is make them more comfortable treating what we would consider from a mental health perspective, mild to moderate level needs in primary care. So they don't need to make those referrals to the higher level needs. So something like anxiety or depression, there's, pretty clear guidelines about how to treat that, or even trauma. And then the other thing we do is that the primary care provider will talk to not only a child psychiatrist, but we also have licensed independent clinical social workers available, so that the primary care provider can hold maybe like the medical piece or the developmental piece of what the needs are. But then we'll also have help from an outside therapist that we're able to find with availability, who takes the patient's insurance and is interested in the challenges that the patient is facing. So we kind of help put together a treatment plan, not just ask the PCP to, figure out a treatment plan by themselves. So we're kind of helping them both learn and provide better treatment immediately.
Thank you.
Yep. And then to your point, if a child is really, really struggling and we're thinking, they'll probably need a designated agency involved, they might need, like a higher level of care sooner rather than later, we would certainly encourage the primary care provider to make that referral. So we do want higher level needs being referred, just not from the mental health perspective. But we also want to make sure that the primary care provider is comfortable continuing to treat the needs that we think can be treated, the mild to moderate level needs in primary care. So if you can go back to the previous slide.
Yeah.
So prior to this model, what we would see is children kind of coming into their primary care clinic for a well child visit. And what we knew nationally is that primary care providers were most comfortable treating uncomplicated ADHD. So they would treat kind of what they recognized and knew how to treat. We also know that there was insufficient screening. So not always, all children with mental health needs would be screened and treated in the primary care clinic. Once a mental health need was identified that kind of exceeded the primary care provider's comfort level, oftentimes those patients would be referred to a specialty mental health clinic or a specialty child psychiatry clinic. And what we also know is that in addition to the long wait lists to see those specialists, not everyone would get to those clinics because of stigma, some social determinants of health, which we just heard about, fragmented primary care and mental health systems, and poor referral follow through. Often families are more comfortable receiving care where they know the provider. So they might say they wanted the referral, but then they might not make it for lots of different reasons. So that's what we're trying to address and kind of hold the primary care clinic, kind of help them both screen more so that they catch the needs that need to be treated, and then also, be able to be very thoughtful with the referrals so that they feel more comfortable treating more of the mild to moderate level needs in primary care. Next. All right, so again, this kind of you can see the red is the child psychiatry specialty system, and the blue is the primary care clinician. So you can see the mild to moderate level needs are receive more treatment right within their primary care home. Next. This is a nice visual of how the service works. So the primary care provider calls at the top. The phone is answered by a licensed independent clinical social worker, and having no barriers between someone who's really comfortable thinking about the treatment that patients need, and the PCP has been shown to be, extremely well received by primary care providers. If needed, the child psychiatrist will be right in touch with that primary care provider based on the primary care provider's availability. And then sometimes PCPs are just calling to get a referral. So they're comfortable in terms of the treatment plan, they kind of know the diagnosis, and they know that the patient needs a referral to, for example, a community therapist. And so then our social workers will use their relationships and their resources to match the needs of the primary care provider with what we know is available out in the community. Sometimes we get a lot of calls about something like, for example, OCD, and we find that the specific therapy for OCD isn't quite available for as many people as we need. And then we'll actually run trainings for community therapists. So training primary care providers with working with other partners like UVM or the ECHO series, or sometimes bringing in our own trainings is also part of what we do.
May I ask a question? So it's free for the provider that is seeking the advice, the
Yep.
primary care. How are
Sorry, I think it's breaking up a little bit.
it's free for the care who's seeking the advice? How are the people responding being funded?
Okay, I heard the last part of your question. How are the people responding being funded? But I didn't, I'm sorry, I missed
Yeah.
the middle part.
Yeah, I'm wondering how they're being funded.
Okay, so how is our service being funded?
Yeah.
Great. We are primarily funded through federal sources right now, and 49 states have similar programs. So many of those other states are also funded through federal sources. So I'm glad you brought that up.
Are they grants, federal grants?
Yep, currently many states are receiving HRSA grants, and that's how Vermont is funding this as well. Yeah.
Right. Is there any concern of the loss of those grants?
Yes, given the federal environment, we definitely have uncertainty around sustainability right now.
All right, thank you.
Thanks for your question. Appreciate it. Next slide, please. All right, so we have registered 100% of pediatric practices in Vermont. That happened within a year, which is kind of a record nationally. So we're really thankful to our partners like VCHIP for helping make that happen. We've supported, this is a hard slide to keep up to date. At this point, we've supported well over 1,300 calls. And we also provide these robust trainings to primary care providers and mental health providers based on what we're hearing the need is. And then there's some work on the national level to better understand how this changes treatment practices for primary care providers, because it's like the $1 million question to answer is like, how does this change treatment within primary care? And the questions that we're answering, we'll answer a question for that one patient that a PCP is calling about, but then the primary care provider learns how to do whatever it is, screening for depression, thinking about OCD, thinking about how trauma and ADHD fit into a treatment plan. And then that impacts their entire caseload. So one call has the opportunity to help that primary care provider provide more rapid, appropriate care to their entire patient population. Next slide, please. Very much appreciative to our partnerships and collaboration, as you can see, our funding sources and VPQ and other partners. Next. And then I think I'll turn it back over to Hillary. I mean, prior to that, I just wanted to end with, you know, we're working and we think this is a very valuable model that can lead to a stronger workforce in which Vermonters receive faster, better care. And it helps decompress the system. As you saw, there are fewer referrals to higher levels of care when primary care providers get the support that they need to treat these kids and perinatal people right within their care, their kind of home-based care system. So we're thinking that this does make care more efficient and has the potential to be helpful for other specialties. Thank you again.
Thank you.
So that's it. We're happy to come back to talk about all 19 at some point, but that's all we have for our project overview today. Would you like me, I did provide a handout with all of our comments related to S-126. Do you want me to just provide a high-level overview, or do you want me to go through each section?
Each section where you're cited and
Okay.
your thoughts around it.
All right, so let me bring up my comments. So we did provide this as a handout. I think just generally, our opening remarks kind of just center on being excited and glad to see quality at the table for these conversations, especially when it comes to the creation of the healthcare delivery plan. I think, and just ensuring that that voice is included. But going section by section, so section 4, we're mentioned in the budget review process to collaborate with the Green Mountain Care Board on quality access cost measures. We're more than happy to do that. We already collaborate with them on this, and I think formalizing that is just fine, and we're happy to do that. Section 8, the statewide healthcare delivery plan. Again, we were encouraged to see quality at the table for these conversations, as we do think it's essential for any system redesign. We really like this section's emphasis on cross-sector collaboration to develop and monitor the plan, creating a space to align efforts, share challenges and successes, and work towards common goals. We just, of course, want to make sure the process is well managed, inclusive, focused on impact, and that we are well positioned to support the plan's development in an advisory capacity, given kind of what we've reviewed today and what we can bring to the table. And we did have some comments, some recommendations for language changes, when we read something like this, considering kind of viewed it as a strategic plan. That's kind of how we read this. And so some thoughts around ways that it can be enhanced to ensure that we're really evaluating for return on investment, the planning process and the outcomes to ensure accountability, transparency, and resource efficiency. So we have some language suggestions in around that. We also, in this section, thought that quality could be called out a little bit more explicitly. So in the plan shall identify section, opportunities to improve the quality of care across the delivery system, enhancements in quality reporting and data collection to provide a more accurate and real-time picture of the quality of healthcare delivery across Vermont, systems to ensure that data is shared and accessible to those providing care. I think I've heard conversations or comments about this from the committee, enabling them to track performance and inform improvement efforts. And that also it should identify exemplars of quality care to drive best practice dissemination and strengthen Vermont's learning health system. This is just a very small, I'm continuing down for this section. There's part where it says it shall identify gaps in access to care as well as circumstances in which service closures or consolidations could result in improvements in, and we recommend also adding or negatively impact quality, access, and affordability. And so, yeah, that's all. Those are our comments for that section. Section 8. May I move on to the next section?
Yes, please.
Okay. So the Healthcare Delivery Advisory Committee, a very small suggestions, kind of, I don't know if our vision for that, just reading it, it kind of seemed like a strategic plan was being developed, and then this is like its board of directors that holds it accountable to make sure that it is monitored, and that, again, a best laid plan plans environments change. So if I would imagine that this plan is a living document, and that as, again, like the federal environment changes, that modifications will need to be made, and that this committee can be responsible for ensuring that this is reviewed regularly and that changes are made as needed. We did recommend that in the advisory committee that VPQHC be added to that as a contributor to the plan's development. Any questions on this? Can I keep going?
No, I keep going.
Okay. So the integration of healthcare data, I mean, generally, we're supportive of any data that we consistently seek opportunities to access high quality, well-governed data that can inform our quality initiatives and patient safety efforts, particularly when it does not impose additional administrative burden. So we're supportive of this section, insofar as that it could support efforts like that. And in terms of cost savings, advancing quality and patient safety not only improves outcomes, but also helps reduce costs across the system. So if this data can be used for that, that's great. VPQHC has been in discussion with AHS about joining the HIE steering committee to help guide the work. Section 12, we just have one minor suggestion here to make sure that this process is inclusive. We are also interested in discussions around the retention of ACO capabilities, particularly those related to quality and more specifically as they relate to hospital settings, because I think the blueprint was called out as maybe being able to carry forward those meaningful parts of the ACO related to data and quality improvement with through the blueprint in primary care practices. The current language, we saw an opportunity to just promote collaborative partnerships in an inclusive process. So we just had a small suggestion here, the Agency of Human Services in collaboration with interested stakeholders. So nothing major. And then maybe I should have led with the appropriation. So this is where VPQHC would need additional resources to effectively engage in this work. It is new work for the organization to be able to participate. If those resources aren't available, we would need to kind of look at this again and maybe recommend that we be taken out of certain pieces of the bill. And that's it. We really appreciate you hearing from us today and considering our feedback on the draft bill. And thank you so much for everything that you do.
Thank you. Speaking of the appropriation, I did have a question at the very beginning of your presentation regarding you have your bill back.
Yeah.
So 29% accounts is in bill back, correct?
Yes. Yep. So it's 660,000 annually.
Okay.
And I can tell you a little.
What is your total budget?
Oh my gosh. I wish our finance person was here. I can get back to you. I can't do fast math. Yeah, I can get back to you with that exact figure.
Okay. I probably could do the math also. If 660 is 29, or I can look over to our JFO and I can see
what is
something way on his calculator. All right, thank you. Any questions for Tucker?
I have one. With all of this wonderful information that you have, I'm wondering if there's any impact on the curriculum of the medical school in the primary care part. Physicians that are being trained at the medical school. Is there anything about mental health or like that changing in their curriculum?
Greta, I think that's a question for you.
What?
I can tell you that I work very closely with Steve Schlossman, who's the director of the child psychiatry department over at UVM. And then I also see every pediatric resident come through rotations in their second year. So I know that the department over at VCCYF provides curriculum and teaching to the medical school, and that Steve and I are in close communication, and he's very excited about collaborating around this program. In fact, UVM staffs 1 day a week of the program, so that's on Mondays. But I think that's a wonderful question. And we've also been thinking about kind of other training programs around the state and at UVM and making sure that we're coordinating with them really well. Yeah.
And how long have you been doing this with UVM? How long?
Yeah, UVM has been part of our program since we started. So a little over 3 years ago, 3.5 years ago. Yep. But in terms of getting the information that we have now and having kind of the buy-in of the primary care providers, that piece is growing every year, every month. And so now we have more information about what's needed, what people are asking for. And so we imagine that those collaborations will just continue to grow as well.
Thank you.
Daisy.
Not a question, but just a comment. I really enjoyed at the top of the presentation, learning more about some of the projects you're doing, and some of the projects I was already familiar with, and not that VPQHC was behind them. So they're really impressive results. And I just want to say thank you for what you're doing for Vermonters.
Thank you so much.
Thank you. Thanks for joining us, and thanks for your thoughts and your written testimony on S-126.
Thank you can I just add one more comment about our bill backs? I feel like I didn't. Those resources are all allocated already. So the Department of Health oversees our contract with our bill back funding. And so that contract is filled with activities already. And it's rewritten every 2 years. So if you have any questions about the bill back and kind of how that works, just please feel free to reach out.
First, thank you.
All right. Thank you so much. Take care.
You too.
Bye.
Okay, why don't we start with Devin Green from, let's pretend it's 11 o'clock.
That's not.
I'm giving her a hard time, but
Devin Green from Vermont Association of Hospitals and Health Systems, and thank you for pretending that it's 11 o'clock. I deeply apologize for not being here earlier.
Yeah, I guess so.
You really appreciate this opportunity to come in on Section 7 for S-126 and going back to contracts and submitting contracts to DFR and the Green Mountain Care Board. I did just want to point out that the Green Mountain Care Board does have extensive authority or broad authority to request information from hospitals and anyone that they regulate. They have the authority. So under 18 VSA section 9374, they have the authority to issue subpoenas, examine persons, administer oaths, and require production of papers and records to carry out its duties. So we do think they have plenty of authority to request contracts now. They have requested contracts from hospitals in the past. And so that authority is there. I think our concerns are similar to what you heard this morning, which is, can we make sure that confidentiality remains in place? There could be potential issues with vendors or things like that that we don't want to see. The other piece that I would ask also is that this sort of mashes together the Green Mountain Care Board and DFR in terms of requesting data, and it would be new for a DFR to request data from hospitals. They have oversight over the insurers. Green Mountain Care Board has oversight over the hospitals. We would want it to remain clear that that oversight is not changed by this and remains. And I'm happy to submit language by Tuesday clarifying.
this language, I'm just thinking as you say that. So DFR currently regulates payers that are in the state, only a few of them. They don't do hospitals. However, this would allow them to look at contracts that hospitals have with other payers that are not in this state, would it?
Potentially under this language, I would think So,
So if insurance company B does not fall under the purview of DFR, DFR could go to the hospital and say, give us your contract with company B.
under this language, yes. Under the bill as it's currently written, the other way to do it is the Green Mountain Care Board could ask for it and then give it over to DFR, because there's that sharing provision
Okay.
in other sections.
All right.
Can we verify that with?
Yeah, I'm not.
You sound like that was something weird about
Yeah, yeah.
There is a lot of confusion around this section, which I just briefly, as our legislative counsel was walking out, I asked, and she sort of assured me that there's some things that are not right in here
Okay.
right now. Yes, but unfortunately, I think she has to go downstairs.
Okay. Yes, so happy to submit language. on this.
Thank you. Thanks for coming. Okay, it's lunchtime, everybody. All right, back to 2:00. So, you know, as we're going through this bill, I was sort of thinking, you know, as we're developing a statewide, strategic plan, I still can't get the right words for it. You know, we spent an awful lot of time talking about in this committee about primary care, our system of primary care within the state. And we just heard from VPQHC, how they're trying to support primary care in the mental health space. And I thought we should probably talk to some primary care physicians. So we have a few physicians here who are on the primary care advisory group, which is kind of housed in Green Mountain Care Board, not housed, but facilitated by the Green Mountain Care Board, maybe.
And nurses.
Yeah. And nurses. Oh, okay. So love to hear your thoughts on 126, and also really just sort of want to get your thoughts around the advisory group and discussions you've had, and what you feel we could do in the primary care space to support our total system of care. So welcome. And I don't know what order anyone would like to go into.
I think, can you hear me okay?
Yes.
I think I was gonna go first, and then we're gonna go with Faye and Michelle, who's a nurse practitioner hospitalist, right?
Great.
Michelle,
Thank you.
am I getting that right, Michelle? I did it right? Okay, good. Yeah. Well, thank you, all of you. This was a really nice invitation, and we kind of scrambled to put some things on paper. I sent you my testimony 5 minutes ago. So with a grain of salt, if that's helpful, like if it says something, it was so valuable to have an invitation to talk about this that I was literally like, I'm going to do everything I possibly can in the next 12 hours to write this thing.
I'm
So
sorry for the last minute invitation.
Oh, no, I'm just really grateful. Honestly, I'm saying that as a positive thing. I mean, I saw patients all morning and somehow was able to crack this thing through. So if it's a little shoddy or a little blunt, I apologize. That's a less refined version of probably a better way of writing it, but it is what it is. So basically, as you said, the Green Mountain Care Board established a primary care advisory group in 2018. And this was intended, as your purpose stated, to sort of give advice, input, or recommendations to kind of whoever wanted to hear it. And we've met since then about every other month. I was a fairly delinquent partner for a few months with other duties, but went to the meeting this past week, and we were talking a lot about a lot of things. I think the thing that's really important is that the messages are coming from a variety of primary care providers who work in all different settings. So hospital practices, FQHCs, private practices, direct primary care practices. and also a lot of different kinds of providers. So you've got docs who are new to practice, you have docs who have been in practice a long time, you have nurse practitioners, you have physician's assistants. So we're really trying to represent the state and all of the provider types who are seeing patients in primary care. And despite those different sort of lenses, we all really have a lot of the same concerns and recommendations. Now, keep in mind, this group has been in place since 2018. 2 years of that were sort of absorbed by conversations regarding COVID. But since then, the biggest conversation is what we have been talking about in the past year, which is costs. It's been going on for years that we've been worried about cost. And I think at the primary care level, we see the inefficiencies of medicine and the costs, sort of not irresponsibility, but the excess cost that doesn't have to happen better than any other people in medicine. So on any given day, I can save this state $50,000 and point out a lot more than that in just inefficiencies that didn't need to happen. So it's hard to know where to direct that information and how to fix it. So that's why we welcome this. It just seems like one era, because we really haven't had, as the PCAG, we haven't had as many invitations to be included as I might have expected, being sort of a charter member of that group. We do report, or we advise the Green Mountain Care Board. But for example, the Act 167 that came out last year, we were interviewed, we participated in some of the fact finding, but never really part of the implementation or the actual sort of what should this report look like? What would be a good recommendation? Are there problems with these recommendations if we put them in? So I think one of our points is going to be to have more of these, have more closer conversations with action items and with troubleshooting issues as primary care builds its support and its funding streams. So what you can read my testimony, but basically what we're trying to do is balance a lack of access, a real need for healthcare in the state with exorbitant costs. So it's this incredible paradox of we are spending so much and yet people aren't necessarily getting the care that they think they need or that they do need. And I admit that I am coming at this from my lens. I come from the lens of, a physician, a primary care physician in a small, in a rural community in an FQHC. So if I was a different provider, I might be coming from this with a different set of priorities. So I'm just trying to be unbiased about that, as we all are, and also trying to stay evidence-based. And so those are two sort of recommendations I would make as we move forward, because in medicine, we're always trying to stay evidence-based because it's very easy to get derailed by a patient or by people who have a lot of emotions about a specific topic, but it may not have the evidence to support it. And I'm not saying there's any one specific topic happening about that right now. I'm just saying I see that a lot. So I want to make sure whatever happens moving forward is really driven by evidence and carefully looked at. So that's my sort of first priority, would be evidence-based decisions and really following that evidence, even if it generates occasionally unpopular results. Primary care funding is going to come up across the board. That's going to look a little different depending on the provider type, but we know that robust primary care, well-supported primary care will save you money in the long run. So when we talk about cost cutting, actually investing in primary care is always going to be an important part of that. And so one of the asks or recommendations would be to improve the primary care spend rate, which has been very stagnant at 4 to 5% for Medicare, Medicaid for a long time. So 4 to 5% of the entire healthcare budget is in primary care, and we see 50% of the visits. If you were building a business, you would never start with those numbers. Improved PCAB involvement with policy development, that's sort of my third, and I've sort of touched on that already. I can get into the weeds on a few of these other things, but they really do save money. And I think that was one of the goals with these acts and this act and this asks. How different people are paid for high level procedures and things like that would improve income streams for organizations like an FQHC and also decrease unnecessary specialty referrals. One of the biggest things that we talk about a lot in the PCAG group for a long time is just patients being seen in the right place. So right place medicine. You know, a lot of patients will end up with an ER visit or a specialty care visit for something that I could have managed. That really clogs up those wait times and decreases the availability of appointments for things that I actually do need to go to the specialist or the ER. So sometimes figuring out ways to better sort patients and improving that location of care, because that would really save a lot of money when patients are in the wrong place for the care they need. So just looking at the number of orders that are done, especially in the hospital setting, all of those really add up. Trying to figure out how to incentivize careful ordering practices. When I think about the billions of dollars that Vermont spends on healthcare, every single one of those dollars started with somebody's order. And I don't really think that all of us think about it that way, but that's another way to look at it. Like, what are we doing to address that? I'm almost done. When you're in primary care, you kind of have two different jobs. One is managing your patients for the day, and that's sort of what we all think about, seeing the patients that come in. The other is managing your panel. Panel management are the 1,500 patients who think of myself as their doctor. And every day I get hundreds of labs, images, orderings, like referral questions, phone calls that I have to deal with, and it's all unpaid work. So capitated payments as a partial pay to some extent help cover some of those costs because it is a lot of hours. It's unpaid. This leads to a lot of burnout and a significantly a lot of difficulty in terms of balancing books for an organization like myself. Almost done. Pipeline. You know, we've talked a lot about pipeline. People always say, I wish there were many more of you. Well, we created the Maple Mountain program, residency program here. I don't believe it's a top priority for funding at this moment. I would hope that that could change. That's the way to build more primary care providers in rural communities. That and other scholarship programs similarly would support nurse practitioner and physician assistant primary care providers in rural communities. So really supporting the pipeline, these are investments that would decrease costs long term. And then just smart spending and technology. So yes, I looked at the bill that we are reporting on that you're all talking about 126, and there are a lot of really good starts in there. I think it's just so important that we're talking about it. But when I kind of reflect back on the last 10 years and where we are now, we really need the primary care advisory group or at least primary care providers to be as close as possible to the decision making so that we can explain, even at the most granular level, how cost differences can be so significant. And it's everyday stuff for us, and we're happy to be here. We're happy to help share that information because we know that it would make a huge difference and decrease costs across the state.
I think Mari has a question for you, Dr. Mevin.
Just a comment and a thank you. I believe I remember you testifying in front of House Healthcare when I believe the chair was Representative Lippert. And I remember being really impressed with exactly what you were saying to us today too, including about providing the right care in the right place and how much could be done in a primary care setting that is now often referred to higher levels of care. And we often have, every year, we talk about the pay rates for primary care and how can we improve that given the constraints that we have And we also talk about how we need to shift towards, much more towards primary care, and yet here we are, you're saying the same things that you told us however many years ago. So I'm just guess putting a pin in it. And just so you know, there's also a sign on our wall that says bang head here. I totally support everything that you're saying, and I think it's really important.
I mean, there have been some initiatives that have come out. Stephanie, who's there, can share the name of the person, because I'm blanking on her name, who gave a really great talk at our Vermont Medical Society meeting last year, which encourages specialists to really redivert patients back to their primary care provider for continuation of care. It's just it's a mentality that has got to change. I think supporting primary care providers from just a public standpoint, that they are competent, they can be the first place to go to for care. Many patients just don't even really realize that. I constantly feel like I'm telling people that. And yeah, it doesn't feel like the needle's moved a whole lot, to be honest. So I really am hoping for things to improve. Some of it is patient driven, so we spend a lot of time educating people. I mean, the other way to look at it, and this is the kind of thing that, I wonder if it's crossed anyone's mind, is, I do recognize that the Oliver Wyman report resulted in some payments that are going to be coming from the medical center, which are sort of under debate. And this is me kind of half knowing things, so I apologize. I don't know all the facts. But if that's sort of like a fine, for lack of better words, for sort of doing well financially, and if that gets directed towards primary care, is that something that we should look at as a recurrent process? Because that sort of helps redirect that sort of specialty level care back to primary care indirectly. Well, that's just a thought. But I think like incentivizing getting patients back to their primary care providers for more efficient, less fragmented, less expensive care is really important. But we have to have the staff and funding to take care of them once they get back here. And that's where I'm just dying, because we closed one of my offices, as you may know. I mean, my Stowe office is closed. So it's really scary to try to hire people to take care of more patients in this sort of landscape. And even scarier, which we haven't talked about, is just trying to hire nurses who can make $7 more doing just about anything per hour. So I'm really worried.
Dr.
And then I
Mama,
think Faye was going to go next, if unless there's specific questions, but I don't want to take over from their opportunities to talk.
I have one question, which I've kind of been asking over and over in this bill. And I know you practice in an FQHC, and I know that you said that MPCAG, that there are providers that practice in every type of setting that you can. Do you think, because you talked about orders, every dollar that's spent started as someone's order. Do you think that primary care, specifically primary care, do you think it is more cost effective if it is delivered outside of a hospital system or inside of a hospital system?
I think that that's exactly why my first bullet point is I don't have a degree in health policy. This is information that somebody can tell us, but I'm a doctor. I don't have that information. I mean, I think it's a really good question, and I'd love to know the answer. And like many other things, if that determined a lot of decisions, we should know if the answer is correct. So I wouldn't want to guess. This is like me guessing about something medical that I'm not 100% sure about. I wouldn't want to know the answer to that before I gave you an answer. And even just guessing wouldn't be fair. So as far as I know, primary care across the board in any setting is the most efficient way to deliver care. But So I don't know that it would be less efficient in a hospital system, but I really wouldn't want to guess without having that evidence in front of me.
Thank you. Dr. Holman, welcome.
Thank you. Hi, everyone, and thank you so much for inviting us here today. I'm Faye Homan, a family doctor in a federally qualified health center in Wells River, Vermont. And I think Katie's enclosure that she shared with you has great information in it. I just have a few things to add. And one is that none of this supporting primary care really is about spending more money. We're spending plenty of money. We're just spending it in the wrong places. And so when we're looking at how to do payment reform, I think the thing to remember in the back of your mind at every moment is the question of, is this moving more people out of tertiary care and into primary care? Because you're going to get more bang for your buck that way. That's been well established for a number, many years, that it's better care and less expensive care in primary care. So every step of the way, how can we move more people out of tertiary and into primary care? With PCAG, we have had lots of great ideas, and yet we often run into this problem, which is that there are certain things in healthcare that the state is in charge of, and some that Green Mountain Care Board's in charge of, and some federal, of course, and some legislative. And so as PCAG, as this group of people who are really engaged in this work, I don't think we really have any teeth. I don't think we have any ability to move the needle. As Katie mentioned, we were sort of consulted on the Oliver Wyman report, but not with the recommendations, just with kind of giving input from the beginning. So one question I have is how to make, I don't know if an advisory committee is the way to have those teeth. I think either our relationship as an advisory committee with the Green Mountain Care Board maybe needs to change a little bit, or maybe it's a somewhat separate ask, but we need primary care advising that has the power to move some of these other organizations. We have talked in PCAG about a czar of primary care, and we've talked about it kind of jokingly, but I actually think it's a great idea, that there has to be some primary care advising that actually can move the needle on the behavior of all of those organizations that I mentioned. In my outline, which I will send after this, I was scrambling to put it together too right before the meeting. I will send it along. And what I have, I think, is suggestions that would maximize what we can do in primary care. And some of them are basic and actionable and cheap, and we just need some way to make them happen. So a huge thing that would make a difference in my practice with keeping more people in primary care and decreasing specialty care would be, as Katie mentioned, to have specialists return the patients to us when they've been consulted by the specialist, have them come back specifically to primary care for their follow-up, not continue to be followed up for controlled situations by the specialists. Have the specialists designate which patients need to stay in specialty care and which ones are ready to go back to primary care. Have access to specialists pre-referral. If I can get a specialist on the telephone, I can give so much better care. Many I can keep out of specialty care. Many I can do just in an extra lab, an extra x-ray, so that when they get to specialty care, everything's teed up and the specialist can weigh in on it. We have a terrible time with communication at this point with our specialists. And that includes sometimes getting 30 and 40 page reports on a single office visit in a specialty care, and emergency room visits and discharge summaries from hospitals that are so long that talk about administrative burden. I have saved a 163-page discharge summary from a hospitalization on one of my patients. It's my job to sort through that and see what my patient needs. Is 163 pages long. So there are things in there that I just mentioned, just in terms of our relationship with specialists, that could be worked on immediately. But it would have to be by somebody who could help move specialty care, tertiary care behavior. And certainly PCAG doesn't have that power. There are a lot of engaged folks on PCAG, and we would be happy to provide lots of stories and lots of input. And as Katie mentioned, sort of payment reform, I think, is at the root of all this. We need to incentivize primary care to have the broad scope of practice. You want us to be doing the MAT program, the joint injections, the skin biopsies. You want us to be doing that in primary care. But the way payment is currently set up, it's often easier to send people off to specialists for those things. So every time there's discussion about payment reform, I think the question really has to be, does this help keep people in primary care? In my outline, which I will send along, there's also a number of suggestions about building the workforce for primary care, and I will send that after this. I think that's most of my thoughts here, but there's lots that could be done. PCAG has lots of suggestions. We don't know how to make it all happen.
Any questions for Dr. Holman? I wanted clarification on something that you mentioned. And I'm trying to think about how you would even implement something like this. But it used to be a primary care ordered, made a referral to a specialist as a consultation. You know, please see my patient. Here's what's going on. Please render your opinion. And then it was sent back to you with the consultant's notes and here's what I found, and go forth and do good, or whatever it was. And now that I, you know, based upon what you're saying, is that you're seeing patients hold that specialists holding on to patients longer, and for continual treatment rather than more of a consultative role. How could that be addressed? What sort of enforcement could happen so that that's not happening?
So yes, we see that all the time. Patients with COPD who see a pulmonologist, and then the pulmonologist will see them back once or twice a year. When they're stable, they're on their inhalers, there hasn't been a change. That shouldn't happen. We can't get our super sick patients in to see specialists right now. The delays are extraordinary. So people who are stable on their therapy should not be seeing specialists. How you get to that point, I think there's some reasonably simple things that could be done. I think that at the end of every specialty visit, if you ask the specialist to check a box, this person is stable to return to primary care, or this person is unstable and needs to come back and see me, not automatically getting a follow-up appointment at tertiary care, but really a conscious thought, is this patient stable to go back to primary care? I think that would be a start. In a sense, that's like a quality measure, and Lord knows we do plenty of those in primary care. I think we should have our specialists take part in that as well.
I can also comment to this. There was I've talked with a lot of specialists about this, and they kind of agree with us. They're like, yeah, I don't really want to do primary care either. Like, sometimes the patients just think that this is where they have to be. Like, they don't have faith in their primary for whatever, to manage their diabetes, and I don't know why. I'm trying to work to change that, but there's sort of this expectation, like I should see a dermatologist for my skin checks every year, et cetera. And we're not picking on individual people. We really just recognize that we need all of our specialty peers. We really do. But it does not just add to cost. The other thing we haven't talked about is it just fragments care. So it makes it harder for patients to keep track of their medical record. Labs get duplicated in weird places. Like, I get lab orders that I didn't even order, that I then have to sort of deal with, and I don't know who ordered them. And so, like, it's just confusing. So one of the things that might help also is to have a more seamless EMR for the state. So that would be a significant improvement. It would be a huge hurdle, but I think it needs to happen at some point. So this would be either something that makes all the EMRs talk to each other like Vital, which most providers don't even know how to get into these days. Or it would be one EMR that really is seamless and it will reduce redundancy. And that way I can write in my note, hey, so-and-so, I'm sending you this person. Can you just comment on their heart failure? And then I'm happy to pick back up at the end of the day with their blood pressure management, and that's it. That's all I need. But the back and forth communication is pretty hard between provider to provider with separate EMRs. So that's the IT part of my kind of efficiency. If we could get AI and a seamless EMR and a little bit more technology going, I think that would actually really help decrease costs as well.
If you were able to access Vital from within your own EMR for clinical data, would that be of value to you in real time?
If it was automatic, that would be awesome. I mean, I use eClinicalWorks, and all of the labs from us automatically dump into Vital, and all of the labs from UVM dump into eClinical. Interestingly, my notes from eClinical do not go to Vital, which is weird. So and I've asked our IT people about that. I'm like, they can't read my notes, but I can read theirs. And it's even like we are across the street from Copley Hospital and we cannot read each other's notes, which is really something the patients can't even believe.
Mari has a question.
I'm going to reveal a little bit of personal information, but it's because I think it highlights another issue around documentation, different requirements around documentation from different providers in the primary versus specialty care world. I was referred by my primary care provider to see a pulmonologist because that's the only way the pulmonologist had to see me before I could get a CPAP machine. I've been happily using a CPAP machine for a year. And now the vendor that provided me with the CPAP machine is saying, oops, you haven't seen your pulmonologist in a year.
Yeah.
I signed off. I don't need a pulmonologist. I don't have any lung issues. And I'm yelling at the vendor and Medicare because the vendor is actually threatening to come to my house to take my CPAP away. Seriously. And I said, good luck with that. You're not going to be able to find me. And then I turned off.
No, but these are the issues that we have to troubleshoot every day. And that's that work outside of visit time that I was talking about with capitated payments. Yeah. It's endless. I have 100 in my box right now on a Friday afternoon. So, and patients are like, how come you didn't deal with it today? I'm like, because I've got 99 in front of you. But it is really frustrating. I mean, I've had patients who I'm not allowed to prescribe the Humira they've been on for 10 years because they haven't seen rheumatologists. I mean, and I'm like, and I call the rheumatologist. I'm like, so can you see this guy because he's like, you're doing fine. I trust you to prescribe that. You don't need me to see him. I'm like, no, you have to for the insurance company to approve it. So these are just completely crazy and very frequent things that we just deal with that make people leave. They make people leave. We're just like, okay, it's never going to get better. We're leaving. I wanted to say two things, but then I really also want to make sure Michelle gets the chance to talk. So I apologize, Michelle. I guess the number one is that primary care providers, I feel like, are pretty good at saying no, but with explanation. So, good example, patient comes in, I twisted my knee on STAR yesterday, and Dr. Marvin, can I please have an MRI? And I'm like, all right, let's do an exam. The exam's normal. Let's just see how it is in a week with ice. Even if you had an MRI, even if you have a tear, you're not going to get it fixed tomorrow. So sort of taking that less invasive, more stepwise approach to care. But there's actually not an incentive to do that, which I've been thinking a lot about recently. So I don't have to do that. I could order the MRI every time. I could do the referral every time. But for some reason, I have this really built-in level of stubbornness that makes me not want to order things because I know that it's the right thing to do. But if we could incentivize those cost-saving decisions, that would be interesting. The other one that I think is really fascinating is drug prices. So one of the things that's gone up, and you guys got to remember, I am a parent and a patient and a doctor and also the wife of a business owner with a lot of employees. So we, on the back end of that business ownership, carry a massive burden for taking care of the healthcare of our employees. So when I think about the healthcare costs of things like drug prices, and I'll use GLP-1s, our fun Ozempic friends, as an example. So Ozempic in other parts of the world costs a lot less money. In the United States, it costs unbelievable amounts of money. And it is a really good drug. Like I sort of was like, oh, Ozempic, it's a fad. No, no, no. It's actually a really good drug. It's really hard. It's good for people's hearts. It's good for people with diabetes. I've had people lose a lot of weight that they needed to lose, and they're very happy with it, but they'll probably be on it for a really long time, if not forever. So the expectation that either the state or that patient is going to pay, thousands of dollars a month is just it's unnecessary. As an FQHC, we take advantage of 340B pricing, which brings it down a little bit, which is helpful. But still, the drug prices is a big part. And that's what I was talking about with this evidence-based thing. As a non-health policy expert, I'm learning. It's not what I went to school for, but I don't know what the biggest cost things are. We've talked a lot about unnecessary specialty care, but for all I know, that's a fraction of the actual cost, and it's all end of life care that we should get people on coasts earlier, or drug prices, and we should go after them federally. So I think obviously there's a lot of different angles. It all adds up. We're just sharing sort of our stories on the primary care lens that we deal with every day. Michelle, can I give you the floor, because I want to make sure you get a chance to talk before.
I think Tucker has a question real quick, and then we're gonna get to you, Michelle. Don't you worry, you're gonna have as much time as you wish.
Good, I just didn't want to hog it.
I'll make people stay here till 10 o'clock tonight.
Sit down.
My question is to, I guess it's Katie?
Yeah.
You mentioned that a more seamless flow of information, incorporating Vital would be really advantageous to you. Now, my question is, and I agree with you. Why can't you how come that doesn't happen?
So let me see if I understand the question properly. Why isn't Vital being used more to sort of streamline this?
Yeah.
Like the
to
information across
improve
the state?
that information flow.
I actually called my friend Maureen Gilbert just last week. I was in Maryland. Believe it or not, I've known her a long time. She's great about this exact question. And the technological, just the computer connection parts of it are hard for some EMRs. They don't speak as well together for whatever reason. Like the example of my EMR can't dump my notes in Vital, at least not yet. And then she was also telling me that one of the major issues has to do with HIPAA. So because Vital gives you access to this cloud of patient information, somebody has to hold you responsible as a provider with that access. And the way it's built right now is that it's the employer who holds that provider accountable. So if they did a search and they found out that I was looking in all these charts that I shouldn't be in, it's actually on my provider having an account with Vital, and that is kind of how that's managed, there's sort of like a safety net with regards to that. The reason I asked is I had noticed that a lot of the UVM physicians don't know how to use Vital or are not using it. And I don't think it's any fault of theirs. Most of their information that they need is internal, because they have, for the most part, everything sort of within their community. But I'm just looking at it as one tool to try to decrease redundancies across the state. And I'm not sure it sounds like there's going to be an upgrade to the computer part of it, but it's a year out or something. So
Probably the reason why the UVM doctors don't know how to use Vital is because Epic is hooked into it. They use Epic.
exactly. They don't really need Vital unless they were to look at my notes, but apparently they
Well,
can't.
they need it to do what you're talking about, having a more seamless flow of information.
Right.
But
But
they
then I
don't
talk
even
with my
probably know they're using Vital.
right. But then I talk with my providers, and I said Vital's actually really helpful. And they say, listen, you're asking me to see 19 people today who are really complicated and have high deductibles and want everything done at once. So I don't have time to go into Vital and find a bunch of other things. I need somebody else to do that for me. So
Okay. We gotta figure out a way to make it happen.
Yeah.
Okay. Thank you very much.
Thank you. Michelle, looking forward to hearing from you.
Thank you. And just for the clarification, Michelle Wade, nurse practitioner. I'm president of the Vermont Nurse Practitioners Association, but a member of PCAG. Did work in primary care for over 5 years, am now working as a hospitalist, and I appreciate the 100 and something page discharge summary. And I have to tell you, something that goes along with that is what we get told has to go into it for billing reasons, for quality reasons, et cetera, et cetera. So I apologize for the long discharge summary. I cannot possibly top what Katie and Faye have already said here today. I can add a couple things and certainly open it up to everybody for questions. I want to go back a little bit and do just a touch of history here. I too was one of the more charter members of PCAG, and it was founded at the time when both Betty Rainbow and Dr. Ramsey left the Green Mountain Care Board. And when the Green Mountain Care Board was first founded, there was on the ground people that were either immediately just out of practice or still practicing clinically there. And that was really helpful. And that was really important.
Yeah.
So that's the piece we're missing right now. And we talk about this at PCAG a lot. So one thing I might consider or might think of is, should there be a permanent direct line between the Green Mountain Care Board and PCAG for reporting? Because we don't seem to have that right now. We certainly get asked, and we certainly do report when we're asked, but it's not on a regular basis. Another area that I would just piggyback onto that was already talked about, my piece that I would add here is around the collection, a group of people that we have on PCAG. It is a phenomenal group of providers. We cover most parts of the states, from pediatrics to geriatrics, and I represent inpatient medicine, and everybody else pretty much represents outpatient medicine. But I have to tell you, the amount of positive ideas that get kicked around at PCAG for money-saving initiatives is amazing. Unfortunately, we can't pull them together into actionable items until we get a little bit more direction on how to do that, with some help perhaps in statute with that. So that might be what one of our asks is that if you're going to have this committee, which I fully believe you need some form of it, but if you're going to have this committee, that it has a place to report out to regularly that is respected. I think one of the other things that I would share is that in general, statute, House Healthcare, Senate Healthcare, and PCAG have gotten great about remembering that nurse practitioners provide primary care also. But within this bill, there is some physician-centric language within S-126, and I'm happy to send that in writing. But I just wanted to point out that there is a couple areas that I think perhaps we could look at that. Katie talked about, and I think Faye did as well, the pipeline for providers. If we don't improve a pipeline financially supporting providers, whether it's Maple Mountain Consortium, which Gifford is a part of, along with Lamoille, where Katie is, if we don't support that financially somehow, we're not going to add those residencies. Without adding those slots, we're probably not going to get those residents. All of the data shows that if these primary care physicians do their residency in a rural environment, they generally stay in a rural environment. And I don't know the exact number, but a large number of them actually stay in the general area of where they did their residency. So it's a pipeline that we're looking toward with the amount of people that are retiring in healthcare providers right now. With that also comes my next thing, which is communication. Katie did a good job with this. Faye did a really good job with this, but I got to tell you a story that I think will make everyone in that room chuckle. I admitted a patient a couple weeks ago who had been to the ER at CVMC, didn't like the answer they got, which was 100% correct, by the way, came down the road to Gifford, tried to get a different answer. Because our 2 EHRs do not talk, they got a repeat of every single test within 4 hours, including high value testing of CT and MRI. Patient makes it to the floor. I picked the patient up that evening, admitted them for not a reason I wanted to, but I did. I admitted them, pulled all of that data because I have access to Epic and I have access to EDH. I log into 4 EHRs on a regular basis in order to gather this data. I have the luxury of being able to do this in a small community hospital. My peers at UVM and DH don't have that luxury. They need it data filled into one place. My primary care peers can't do it. They're trying to see 20 patients a day, 18, 16 patients a day, and barely have an MA that can room for them, let alone a nurse to data mine for them. They need help in that respect. But where I'm going with this is that when I presented that patient with all of their records from CVMC and all of their duplicative records from us, and I said, I'm really sorry. We agree with your decision that was made at CVMC. I'm discharging you because I have nothing and there is nothing here that indicates you need to be an inpatient. The amount of money that the state of Vermont on Medicaid for this patient paid for is astronomical. I've seen this repeated over and over again, and I'm sure other colleagues of mine could tell you that. It's happening a lot. The other piece is fragmented care. We all work in a little bit of a different system. My patients who come to me at Gifford often get their primary care in Rutland because we live on a border town. I have no access to the Rutland stuff. I can't see what's going on there. I never know if they see my discharge summaries or not. I try to have them hand carry them back, but I don't know that it works. I know that they're not going into Vital. I do know that. I know also that when I share patients with specialty at DH, because we do swing bed patients at Gifford, so I do a little primary care with my swing bed patients. When I share them to their specialists at DH, I make a point of saying, can this patient stop seeing you unless something else goes wrong because they look stable now? And I have never once had one of them tell me, oh no, they can just see primary care. They always say they need an annual visit. I'll get off my soapbox because I think I want to leave a little time in case there's questions. I will also submit something in writing, but I really appreciate that you guys reached out to us today. I think it's super important that you are seeing the need to communicate with the boots on the ground. I was very disappointed with 167 when it came out after having had personally spent time talking with those folks, and nothing that I shared with them from the APRN level was included in that report.
Michelle, thank you for that. Everything you said, I completely agree with.
Thanks, Katie.
Topper has a question and then Marty does.
Okay, my question is, you made the statement that, and correct me if I'm wrong, that we can't get the interns. We don't have a pipeline of doctors. Is there a reason why? Because we're providing scholarships and loan payment and et cetera to people if they'll stay here.
Katie, you can help me with this, but it's all about the number of residency slots. And what we're trying to do is get more residency slots, and I'll defer to Katie.
So I think there's kind of a couple different ways to answer your question. There is a primary care scholarship for medical school, right? For 3rd and 4th year students, they can pay for a year of school, giving 2 years of practice in primary care outside of Chittenden County. And you're right that fund has not been maxed out. I think there's a really big answer to that, and it's that primary care is not a glamorous, high-paying field. And for a lot of people with really big loans, or if they feel like they want to do something else, it turns into, kind of a backup plan in some cases, unfortunately. So they haven't maxed that out, but they do need it refilled. I think it's sunsetting or just running out. So that was one of the asks I know this year, was to try to like top off that fund for those students that do know. So I have medical students that work with me all the time, and some of them come in and I'm like, what do you want to do? And they're like, oh, I want to be like a peds oncologist. I'm like, okay. But then I have some that come in and they're like, I want to do what you do. Or maybe they came in saying, I want to go into cardiology. And then after a week, they're like, I actually want to do what you do. And that's the best. So for those people, we really want to support them. We want to make it easier for them because they're not just paying the same student debt as everybody else. They know they're going into a field with lower reimbursement. And so it takes longer to pay off those loans, and we want to make it easy from the get-go. So even though it doesn't seem like everyone's just jumping at those scholarships and those funds, they are really important for those few that we need. And if you think about it, we don't, I mean, we do need a lot of primary care providers. We definitely do, of all sorts. We need PAs and NPs, and I'm hiring them as if I can, if I'm allowed to, I will. But if you think about a primary care provider, and let's take a doctor, for example, because they have a little bit bigger panel size in the way that we work things. Every one of our full-time physicians can carry a panel size in Vermont, in our area of rural practice, of 1,500 to 1,600 or so patients. Now, that panel size is not a uniform number across the state, and it's really fascinating to talk with different locations, because in some places it's 1,100 or 1,200, in some places it's 1,800. But let's just use 1,500 as a ballpark. So every primary care provider that you drop in these small towns, even if there's like 2, you're taking care of 3,000 more patients, and you're helping a clinic perhaps train or support other staff in that location. So we need every single one of them. So I wouldn't diminish if those scholarships aren't getting like kind of like whipped off the floor. That's okay. We need to keep funding it though for those ones that do want to be out in the rural practices.
I'll also add that in the enclosure that I'm going to put in, there's a section on building primary care workforce. I think the high debt burden and low pay for family docs is definitely directing some of the decisions from our medical students. There's also just a cultural thing that needs to change. And I don't know how we make culture change, but especially when you're trained in a tertiary care center, there's a lot of glamorization of the specialties and a lot of dismissiveness of primary care. And I don't know how that gets fixed, but when you choose your medical students that you're putting into the system, into the pipeline from rural areas, from disadvantaged backgrounds, they stay in primary care in much greater numbers. There's data on that. And so I think there's a lot we could do to increase the pipeline. I think we could choose medical students differently. I think we could work on culture change. I'm not sure exactly how to go about that, but maybe if there's ever a czar of primary care, that can be part of their job. Scholarships, early exposure to rural primary care. Students often go into primary care who have worked with a preceptor like Katie early in their career. Even doing that early career exposure in high school and undergraduate helps students make the choice for primary care. So there's a little about that in the enclosure I'm going to send to you, but also talk to us anytime. We can reiterate a lot of this.
I do want to add one more thing to that. I am a product of that. I started my LPN career and went to school at Vermont Tech as an LPN, and subsequently used that money that was awarded on the nursing side to fund my RN program. Subsequently was awarded scholarship money and worked for 2 years in return as a registered nurse in the state of Vermont, and then went back to school working toward my master's degree. When I graduated with my master's degree, again, got 2 years worth of my loans repaid from the nursing side of the AHEC program. And here I am now 13 years into a career where I'm providing primary care medicine here in Vermont. So it does work, whether it's on the nursing side coming up through for the nurse practitioners or the medicine side. I think the other piece of that question was specific to the rural residency representative. And I think the rural residency Maple Mountain that we're talking about is adding more family medicine residency slots available in the state.
Yeah, I can explain that again a little bit too. So the GME has only a certain number of slots for UVM, and they are over their cap, which are paid for, I believe, by Medicare dollars. So the UVMMC, I think, supports, or the College of Medicine supports the additional slots. This would be a separate GME support. And what's really important as a resident to think about is if you want to come be a resident in Vermont, let's say you're in med school like I was in Baltimore, and I knew I wanted to be in Vermont because I was marrying a sugar maker. I only had one choice. I had to go to UVM. I had to go to Milton, which wasn't bad. I loved it. It was great. but it is an opposed program, which means you're in a big hospital with a lot of other fields also training. So you do have some limitations in terms of what you're exposed to because there's all these other residents sort of grappling for the same exciting cases. In an unopposed program, which is what Maple Mountain would be, you are the only residents in the hospital. So you are getting to be firsthand with the general surgeon, with the OB, with everybody. And that is a very appealing thing for students like myself who wanted to have sort of a deep knowledge base and skill base to practice sort of full spectrum primary care. So that's an appeal that isn't talked about as much, but it would be Vermont's only unopposed residency if it can take flight. So, I really hope it does. I know, obviously at Lamoille Health Partners, my partner, Melissa Volansky, has put her life into this for the last 2 years. And we really, really need that to be supported.
So
Yeah.
Maple Mountain, let's put that aside. What I'd like, if you would, is think about the one thing that you talked about was choosing people that are coming into medical school differently. I don't want to get into a long discussion about that now, and all the culture change or any of that kind of stuff. But if you could think of that and give us some ideas, I think that would be helpful in terms of us trying to figure out how to have the pipeline more robust.
I mean, one of the things that's just the elephant in the room that is sort of along the lines of what you're talking about is that the pay differential with different kinds of physicians is insane. I mean, there are providers who work 100 yards from me who are right out of the residency who make 3 times what I make, and I've been doing this for 16 years. Okay, and that's crazy. I don't even like to think about it.
Yeah.
And I'm taking care of, suicidal teenagers and doing home visits for people who are dying and like a lot of really hard, important work. It's just not reimbursed at the same kind of rate that procedural specialties are reimbursed. So that's a very big problem, but the cost differential, that is a very big part of how students have to make their decision if they have humongous loans and if they just want to make more money.
Laurie.
Okay.
I have a comment that I really don't want to talk about, but I just want to throw it out there.
The safe space.
Safe space, yeah. The Trump administration is currently attacking GME, the organizations that accredit for medical education. So I'll just throw that out there. And the thing that I really wanted to talk about was I really like the idea of PCAG having teeth. And I'm in many ways trying to visualize literally and figuratively what that would look like. And I think that does need to happen. I remember when I was being taught how to drive, I was always told that you need to look at where you want to go, and then you will be heading in the direction that you want to go. And using that analogy, we're by necessity, mostly by necessity, having to have our direction and our view split in so many different directions, just trying to keep everything together. But I think it would be really important to have PCAG or an organization like PCAG, like all of you, in an official role with authority and whatever kind of teeth we could imagine, so that we're not coming back for 5 years from now and having you come back, Katie, and saying the same things that we haven't gotten anywhere.
Yeah, I mean, I think improving the primary care rate, even by 1% per year, would be a really good start.
But I think having you all be leaders and allowed to be leaders in the transition toward primary care, I think is really critical. And I hear you that we don't have that and that you weren't necessarily heard in the the Act 167 process.
If there's one thing that's also important to me, I mean, obviously I have the bias of working in an FQHC. I really want to make sure that we don't polarize different working primary care groups sort of against one another. There's a really good reason why there are direct primary care and private practices. Sometimes it sort of comes across as like we're competitive with each other, and we're not. I'm so supportive of every different model. I think they're all important. They might involve different solutions, but that's a really critical part that I just wanted to point out. And then I think, like, if there's one thing that could improve is, and it might be a federal level thing, but for those people that do work for an FQHC but have the wheelhouse of high competency skills, is trying to figure out how to reimburse those in the same way that you would if you were fee for service. Because as we've pointed out, you know, it's very disincentivizing to, you know, spend an hour with a patient doing a high complex procedure that we were trained to do and bring in the exact same number of dollars as the 5-minute strep throat you saw earlier in the day. And that just doesn't seem to make sense. The only FQHC that I know of that's doing really well is actually in Glens Falls, New York, run by my friend Tucker Slingerland in Heads and Headwaters. And he's created a model that is doing great, but he's really big. It goes all the way up the west coast of the Hudson to the Canadian border. So he's got some sort of special sauce working over there, but I don't know that the FQHC model in the way that we're doing it in Vermont right now is very successful, because seems to me they're all struggling.
I would just piggyback on what Katie just said and say that when I did work at the FQHC in primary care in the Rutland area, we were encouraged to send out all of our procedures and to not do them so that we could be a patient mill and see more and more and more and more patients for the strep throats, the ear infections, etc., because we weren't getting reimbursed as we should be for the procedures. So that is probably a federal issue, but I will also say at the MD level, it's a little better, but at the nurse practitioner level, there is zero education about billing and or procedural billing and how it affects everything. So that's something else that, you know, perhaps the feds don't realize exactly how much we are doing, because if it's not billed correctly, they don't see the bottom line. Just throwing that out there.
I was just thinking we could fix that whole specialist hanging on to patients by just paying specialists a global payment, and that's all you get. They probably wouldn't hold on to them very long, but that's what we do in primary care. I mean, that's what we do in primary care. So, you know, the combination of fee for service plus a global payment, you have to have both.
You have to have both.
Seems like the only, I'm sorry, I'm editorializing here, but it seems to me we talk so fee for service is bad, but the only place you really want to incentivize fee for service is primary care, because the more they bill, the better for the whole entire system. The higher their utilization is, the better for the rest of the system.
Exactly.
And-
like if
And
Paul,
we've inversed it.
right? Like if Paul or I do a knee injection, right? It's going to be X number of dollars. But if I have to ship that person and they're Medicaid, the state's going to pay a bill no matter what, right?
Yeah.
Do they want to pay me to do it for whatever dollars or a different number somewhere else?
Okay. Oh, Wendy.
I want you
sorry.
to ask the normal question that you asked about inside and outside.
I'm sorry, you ask it for me because I'm not sure which one that.
About whether a primary care.
Oh, I did.
You did?
I did. I
Okay.
asked Dr. Marvin
Okay, I'm sorry.
about whether or not primary
Okay,
care
I
should
didn't
be
hear you.
inside should be
Okay,
inside a hospital or not,
okay, I'll ask you.
outside, which is more efficient. She was neutral.
Okay.
She's just like more primary care, the better.
Yeah.
Doesn't care where it
And it
is.
feels like that the entire reform, that's all we talk about is primary care, but yet we're still not rewarding primary care here. Like,
Well, I
it's-
mean,
it's upside down.
right. Well, one of the things, and maybe this is pushing things a little too far. But
Go
as I
ahead.
started out with, we have a spend rate for primary care of 4 to 10%, which means 90 to 96% is not going to primary care. So that's what we aren't talking about. Those dollars have to go down. And I don't think that the right thing to do when to ask for those dollars to go down is to close primary care. That seemed like that was the wrong decision for, at least in my opinion, this is totally my opinion, but that was to me not the right answer to the request to cut that 96% down, to cut, so I think that 96% has got to take some real look at themselves, some ownership, and figure out like, where are these expenses coming from? Is this all evidence-based medicine? Like, where are the costs? And like I said, is this ordering? Is it the length of stay because we don't have places to put people? Maybe we invest in home health or something to fix that problem. Is it drug costs? So then we need to go after those companies federally. Is it like end of life care super expensive and we could be better about our DNR and DNI orders? So these are the things where I'm like, what is it? I need to see the list of the top 5 things in that 96% and like try to go down that checkbox and say like, how do we fix these 5 things to make it more like 80%? Because that would put 20% back to primary care with no increased price tag.
Absolutely. Thank you. Daisy has a question?
Yeah, this is back to a point you made. I forget if it was Dr. Marvin or Michelle about FQHCs being incentivized, if I understood correctly, to bill. And I thought that FQHCs were billed or bill according to a PPS rate. Is that not correct? And if so, how is that incentivizing them to bill more?
I think it was my comment you're referring to. And I think a good way to explain it is that it's told to a new provider when they come in often to an FQHC that we get X amount of dollars for your visit, irregardless of whether it's a 9921345, whatever number you bill. It is important, however, that it is billed correctly because that's what sets the rate for the following year. And that's the piece of the bucket that gets missed sometimes. And that was what I was trying to say that I did a poor job of saying.
But that's just their first year when they're establishing their PPS rate, right?
I would have to go back and get some more data. My understanding from my billing department is that it's reviewed annually. But I would have to get more data before I can say that for sure.
Thank you.
And wasn't there an article recently that talked about increased rates for FQHCs? And I think Faye, the Wells River was the only one that got some sort of bump in terms of rate increase for the flat rate, right?
We did, and that is a mystery to me about why that happened, except maybe that we had been underpaid for the previous several decades. But I think one of the points about the FQHC payment structure is that once your payment per visit is established, you get that for long or for short visits. And so an example reflecting something Katie said is, when I see somebody and I do their joint injection, I'm also checking in with them about their depression and their blood pressure and the back pain they complain about at their last visit. And I can only bill the knee injection, let's say. If I send that patient to ortho, the knee injection is extraordinarily more expensive because they get to put on these facility fees and that sort of stuff. But our incentive in FQHC is to see people quick visits for single issues. What is really good healthcare is long visits where you take as much time as the patient needs with you. So, I mean, I love my FQHC. I'm not complaining. We wouldn't be here without the FQHC program. There's no way we would be in practice. But there are still incentives within how we're paid that work against really having the time that we need with our patients. As Katie is pointing out, the administrative burden. I mean, I get paid for a 7.5-hour day and I work 10 to 11. And that's true for everybody in primary care because there's that much work to do. And if that were evened out a little bit, we'd be given better care and perhaps even having more time to see the people who really needed us.
All right. Well, thank you so much for joining us today, especially short notice. Lot to think about as we go into S-126 next week, which we're going to start with, kind of going through and marking it up or deciding what we want to do with it as we move along with it. Okay.
We
So,
are happy to talk anytime. Thank you
Yep.
so much for asking us.
thank you.
Thank you.
Thank you. Thank you.